Hey, it's Dr. Matt. It's been a while. The long and short is right after the last video that I posted, I had a couple days where I just crashed and burned before I went to Colorado for the emergency conference. And then when I got back, I worked 90 hours of overnights. So I've been slacking, but I don't want to do a video if I'm extremely tired. It's just me. Anyway, as a reminder, my name is Dr. Matt Crawford-Jennings. I'm a veterinarian, and I also happen to be a first-year emergency and critical care resident at North Carolina State University's College of Veterinary Medicine Veterinary Teaching Hospital. As usual, as I say, that North Carolina State University does not endorse, nor are they affiliated with the presentation. So one of the first medications that I wanted to cover was bicarb. Bicarb used to scare me big time in my internship, and now I've used it a few times and I feel pretty comfortable. So, things we're going to cover today. What is it? Why? Why not? How to? What can we see as adverse effects or drug interactions? How to monitor? And when do we actually use it? So, what is sodium bicarbonate? So, it's a sodium cation bonded to a bicarbonate anion to form an amphoteric salt. Also has a pK of 6.3. If you remember from forever and a day ago, amphoteric means that it can act as both an acid or a base, depending on the situation that it's in. Normally, sodium bicarbonate's a weak acid, but it does readily decompose to carbon dioxide and water when exposed to an acid. But when it's exposed to a base, it forms various forms of carbonates and water. The molecular weight is 84 grams per mole, which I think is very useful, especially when we are using the 8.4% solution, just because I like when the numbers are very similar. And then the pH, depending on the solution and the manufacturer, varies from neutral at 7 to basic at 8.5. So just a fun fact, so sodium bicarbonate only has one carbonate ion, but it got the name as bicarbonate because it produces twice as much carbonate as sodium carbonate. It's a little confusing, but also wanted to mention that the FDA has approved the use of sodium bicarbonate in people for cardiac conduction delays and QRS prolongation, for example, in like tricyclic antidepressant toxicity. And then the non-approved or extra label use is nebulization for chemical injuries from chlorine gas. So sodium bicarbonate in the body. So what it does is it binds the hydrogen or free protons to form carbonic acid, which is this molecule right here, and dissociates into carbon dioxide and water. What happens then is that the carbon dioxide and the water are catalyzed by carbonic anhydrase to form carbonic acid, which then dissociates into bicarb and protons, with the protons being renally excreted, so moved from the proximal tubule cells into the tubular lumen, and bicarb binds more protons. So that's usually released back into the blood or the plasma. And then carbon dioxide is typically removed from the lungs. And this image you see here, we'll see it many other times, and we'll go over it then. Essentially, the kidney's doing the whole job of reabsorption. But the thing to know is that the majority of it is reabsorbed in the proximal convoluted tubules, with pretty much not very much going on in the distal or anywhere else, which is important to understand for diseases like proximal renal tubular acidosis. So what happens is there's a decreased reabsorption of bicarbonate, which leads to the pathology. In contrast with distal renal tubular acidosis, it's that the distal tubules cannot regenerate or make more bicarbonate. In this schematic diagram you can see here, it's basically illustrating that hydrogen ions are secreted into the lumen via the apical sodium hydrogen exchanger and the hydrogen ATPase transporter pump. So kind of like what we've already talked about is that bicarb forms or reacts with a proton and is made into carbonic acid via carbonic anhydrase type 4. And then the CO2 diffuses into the proximal tubular cell, which is then catalyzed by carbonic anhydrase type 2 with a base or a hydroxyl group to form bicarbonate, which will then go out into the interstitium and thus the plasma. So in renal ammonogenesis, so basically with the acid base in the kidneys is that in the proximal tubule, like we said, it's primarily responsible for reabsorption for approximately 75% reabsorption of bicarb in the kidney. And primarily what happens here is that they're trying to excrete the ions and conserve the sodium through the generation of ammonium from glutamate and the proximal convoluted tubules. And this is the kidney's primary compensatory mechanism in the face of a primary respiratory acidosis. For the NBCN1, it's an electroneutral sodium bicarbonate co-transporter that facilitates coordinated transportation of ammonia into the medullary interstitium and the movement of bicarbonate into the cell. So essentially, when you have one molecule of glutamine, it's eventually going to turn into 2 molecules of bicarbonate. And again, in the distal convoluted tubules, you're primarily going to have bicarbonate generation. So what happens is that the hydrogen in the distal convoluted tubular lumen reacts with the bicarb to form carbonic acid via carbonic anhydrase, which is going to catalyze it into carbon dioxide and water. The CO2 then enters the tubular cell and reacts with water molecules to form, once again, hydrogen and bicarbonate, with the hydrogen being excreted into the tubular lumen and thus in the urine, and then the bicarbonate is reabsorbed from the interstitium into the plasma. And what happens here is there's excretion of titratable acids. The hydrogen or the proton ions are going to bind other bases such as phosphates, which is another major buffering system in the body. And this is just kind of another stylized diagram. So, indications for therapy. So there's a few. So severe metabolic acidosis, also called NAGMA or normal anion gap metabolic acidosis. Hyperkalemic or hypercalcemic crises, post-CPCR or prolonged CPCR, certain toxin exposures, and then prevention of contrast-induced renal failure, which is more so in people. So controversial, again, everyone has their own feelings about which way the toilet paper is supposed to go, and there isn't necessarily kind of a right or a wrong. So there's a few different types of severe metabolic acidoses. So there's ketoacids with diabetic ketoacidosis, probably wouldn't use bicarbonate. For lactic acidosis, definitely wouldn't use it, and we'll talk about that shortly. For uremic acidosis, if it's that bad, possibly doing it with or in the face of hyperkalemia and using isotonic bicarbonate. So since it's so hypertonic, you'd have to dilute it into something that is more hypotonic, like D5W. And then kind of the meat and potatoes is a hyperchloremic normal anion gap metabolic acidosis, typically due to really severe diarrhea, renal failure, or renal tubular acidoses. Other names that we know it as is hyperchloremic metabolic acidosis, or again, NAGMA, which is normal anion gap metabolic acidosis. So with renal tubular acidosis, just quick. So with proximal, you're going to have impaired bicarbonate reabsorption. Remember that the proximal tubule reabsorbs about 75%. And the urine pH is usually going to be basic, but then ends up becoming more acidic. And you have pretty mild to moderate hypokalemia. And then with a type 1 or distal RTA, you're going to have impaired hydrogen ion secretion, and therefore decreased bicarbonate generation. So then you're going to have a basic urine pH with pretty severe hypokalemia and nephrolithiasis in more chronic cases. Type 4 is less commonly realized in veterinary medicine, more so with people like Addisonian crises and such. So in a hyperkalemic crisis, so things that can be the etiology of that would be like cortisol insufficiency, insulin resistance, acute acidosis, urinary tract obstruction or rupture, acute renal failure, drugs such as ACE inhibitors, NSAIDs, and RAS inhibitors, rhabdomyolysis, severe hemolysis, and then digitalis overdose. So what you can do is you can give the sodium bicarbonate, and what that's going to do is induce a transcellular shift. So you're going to have the extracellular or the potassium in the blood go into the cells, driving blood or plasma potassium down. However, before you start giving sodium bicarbonate for something like this, it'd have to be pretty severe, and make sure you rule out pseudo hyperkalemia first. So sampling error, pretty severe hemolysis or hemolysis in Japanese breed dogs, since their intra-erythrocytic potassium concentration is much higher, severe thrombocytosis or leukocytosis. In hypercalcemic crises, so you can reduce the pH of the blood, which is a metabolic alkalosis, which then increases the albumin binding to calcium to decrease the ionized calcium. So before you go ahead and do this, I wouldn't necessarily do this off of total calcium based off a biochemical profile. So I would use a blood gas. With CPCR, so essentially the reason why you may be giving it is prolonged, so they're having a worsening acidosis. And remember that catecholamines like epinephrine and norepinephrine don't work very well or don't have the body respond to them very well because of the acidosis. So inducing kind of like a metabolic alkalosis may make your catecholamines work better. So toxin excretions, so this is something new to me. So sodium blockers or sodium channel blockers could include the quinidine and procainamide, which are the 1A classification, lidocaine phenytoin, which is the 1B, and then flecainide and propafenone, which are more human medications in class 1C antiarrhythmics. Potassium channel blockers like amiodarone and sotalol, salicylate/aspirin, alcohols, so ethanol, methanol, ethylene glycol, propylene glycol, Benadryl overdoses or diphenhydramine, cocaine, anti-seizure drugs such as carbamazepine, lamotrigine, zonisamide, and phenobarbital. The TCAs and SSRIs such as amitriptyline or doxepin, which are the TCAs, and the SSRIs such as citalopram, venlafaxine, fluoxetine, bupropion, which are relatively pretty common human medications. Others can include like propranolol, amantadine, chloroquine, hydroxychloroquine, and cyclobenzaprine, which are usually more so human medications other than propranolol and amantadine. So reducing the risk of contrast-induced nephropathy in patients that are at risk. So these are 3 papers, and this is pretty new information to me. And when I sit down and read through the papers and thought about it, it does make sense. So the paper up here in the top left concluded that hydration with sodium bicarb before contrast exposure is more effective than hydrating the patient with saline for prophylaxis. In the middle, this meta-analysis suggested a significant benefit of using bicarb-based hydration for prophylaxis of contrast-induced nephropathy, although the magnitude of the benefit may have been overestimated by earlier studies. However, the lack of any study to date showing superiority of saline-based hydration suggests that sodium bicarb-based hydration should be considered the optimal hydration in high-risk patients. And then the bottom study here in the bottom right, patients at increased risk for contrast-induced nephropathy receiving prophylactic theophylline and hydration with sodium bicarb reduced renal impairment compared to hydration with saline, which, if you think about it, so the high load of sodium that you're giving is causing a hypernatremia, which is increasing kind of the plasma hypertonicity, drawing water into the vascular space. So to me, that makes sense as why you might reduce the risk of contrast-induced nephropathy. So how to administer sodium bicarb? There's a lot of different formulations or formulas out there. I've been taught both this one and this one, but I like the one that's in bold better. I have more experience with that one. And then things to remember is that the majority of the solutions, at least that I've seen, are 8.4% solution, which I like a lot because the concentration ends up being 1 milliequivalent per mil, which makes your math a lot easier after doing a bunch of other math that determine the amount. And the osmolality is 2,000 milliosmoles per liter. So very hypertonic and not something that you can give via peripheral catheter unless significantly diluted. So ideally given via a central line or a PICC line. So how to use it orally? So kind of doing it yourself, you can take an 8-ounce box of baking soda and put it in about 2.88 liters of distilled water to create a 1 milliequivalent per mil solution of bicarb, which does hold stable in the fridge for about 60 days. And you can give the calculated amount in the water bowl if the animal is reliably drinking, or you can give it via a feeding tube if they already have one placed. Additionally, for long-term management of renal tubular acidosis. Wedgwood, the pharmacy or the compounding pharmacy, can compound concentrations from a variable strength, which might make it a lot easier, especially long-term for owners. However, if finances are kind of an issue, then you can just have the owners follow pretty strict instructions to make it. How to give it IV. So you can't give it faster than 20 to 30 minutes. And the reason for that is that it's redistributed from the intravascular compartment to the interstitial compartment. If you give it too fast, you can cause pretty significant hypotension, restlessness, GI upset, collapse, and even death. So again, you have all these different kind of equations. I like the one that's in bold. So you're going to do 0.3 times the body weight in kilograms, and you're going to multiply that by the difference between 24 and the current bicarb. 24 milliequivalents is usually about the normal-ish value. And then you're going to give 25 to 50% of this over 24 hours. Be a little bit more cautious, and everyone kind of feels their own feelings about how much to give and over the time. So example, the math's kind of a pain. That's why I wanted to go through it with you guys. And if, you can pause this as needed to follow along. So you have a 25 kilo dog with a base excess of -25 and a serum bicarb of 5. So what you're going to do is you're going to plug in the weight and the bicarb. So what that's going to lead to is 142.5 milliequivalents per day. And I just decided we're going to give 50% of this over the next 24 hours. So in order to draw this out to make it easier to understand, what's going to happen is you're going to be giving just under 3 milliequivalents per hour of bicarb. And because it's so hypertonic at 2000 milliosmoles per liter, I dilute that typically in D5W because it's pretty hypotonic. And the maintenance rate that I chose was 45 mils per hour, just based. You can use 40, 30, 60. It's up to you. This is just how to do the math. So you can kind of plug and chug. And so what you're going to do is you're going to add 66 milliequivalents of bicarb to 1 liter of D5W. And in order to figure out how much you put in is you're just going to subtract that from 1 liter. Luckily, my techs are fantastic at NC State, and they do this for me. But in case you don't have the privilege of that, I think it's very nice to have. So if you want to do it orally or via feeding tube, it's the same thing. So this is just kind of the very basic empirical if you don't want to do the math or you're too busy. So here's kind of the steps. So you would need 50 milliequivalents or 50 mils per day if you follow these DIY concentration solution how-to. And then if you're feeding them twice a day, you just give 25 mixed into the food or via feeding tube. So contraindications. So some pretty important contraindications you need to remember is that if you already have a alkalosis, whether it's metabolic or respiratory, you're just going to make it worse by giving a huge amount of base, right? Another contraindication would be excessive chloride loss. And if you think about it with the anion gap, so you have sodium plus potassium, and then you subtract that sum with chloride plus bicarb. So what the body does is if you have high bicarb, you're going to decrease the amount of chloride to maintain theoretically electrolyte neutrality. So if you have high excessive chloride loss, whether that be from GI losses or pretty excessive suctioning due to increased GRVs, you're just going to drive the chloride loss lower. With the hypoventilation, essentially, you're going to decrease the ventilatory drive, and you're going to lead to worsening accumulation of CO2, leading to worse acidosis, which can lead to intracellular or CNS acidosis, which we'll talk about shortly, which is like kind of what a lot of people are pretty frightened about and why you become kind of like a helicopter mom when you're monitoring. With oligoanuric renal failure or heart failure, the reason why you may not want to use this is because it's so hypertonic. It's pretty easy to lead to a hypervolemia, hyperosmolality, and hypernatremia. And since one of the indications can be a hypercalcemic issue, it can lead to hypocalcemic tetany, or additionally, you don't want to use it in that situation. And then pretty severe hypokalemia, which is an interesting point I want to talk about, and that with the couple of distal renal tubular acidoses being so hypokalemic or low potassium, you have to use the bicarb to try and even out their acid base. So you're essentially going to be using high doses of potassium supplementation, which it's not uncommon to use Kmax at 0.5 milliequivalent per kilo per hour, or even higher with much closer monitoring. So some adverse effects. So kind of like I already alluded to earlier, is it can lead to paradoxical intracellular or CNS acidosis. And what happens is when you're giving all this bicarb and it's converted to CO2, you're leading to an elevation in the serum or plasma CO2 levels. And what happens is when this accumulates, the CO2 crosses into the cells or across the blood-brain barrier, leading to a pretty significant acidosis, which can lead to neurologic dysfunction, alterations in mentation or consciousness, and sudden death. There's some adverse effects. So cardiovascularly, you can read all of these things. The biggest thing is hypervolemia and the decreased tissue oxygenation. Essentially, what happens is the alkalosis-dependent activation of 6-phosphofructokinase, and it enhances ketone body production, which also likely contributes to the decreased dissociation of oxygen from the hemoglobin curve. And if you look at the oxygen hemoglobin dissociation curve, you're going to lead to a leftward shifting. Metabolically, it can lead to a hypercapnia, which we've kind of already talked about. And again, the hyperosmolality, hypernatremia, and hypervolemia. Overshoot alkalosis, and then significantly relevant hypocalcemia, hypomagnesemia, or hypokalemia. Insulin resistance, phlebitis, tissue necrosis, and sloughing if you're giving it via peripheral catheter, or a dislodged central line. In terms of drug interactions, so with antimicrobials, the quinolines exhibit decreased solubility in alkaline environments. The tetracyclines are relatively similar. And then for corticosteroids with bicarbonate, you're more likely to induce a hypernatremia due to water retention and the amount of sodium that you're giving. And then for the diuretics with sodium bicarb, you're more likely to cause a significant hypochloremic metabolic alkalosis. And then if you're giving it orally, it's kind of like sucralfate, can bind to just about a bunch of other things or decrease their absorption or bioavailability. So for monitoring, this is where you might want to be a helicopter parent. So an arterial or venous blood gas, electrolytes, ventilatory and neurologic status, co-oximetry, and urine pH. For the blood gas, you want to monitor your CO2, your electrolytes, maybe even your saturation of oxygen. And a lot of the blood gas machines do have co-oximetry, which you can use to see the amount of oxyhemoglobin to help determine if you're affecting left shifting of the oxyhemoglobin curve to the left, where the hemoglobin has a difficult time unloading oxygen into the tissues, which can drive an increased lactate or a hyperlactatemia, other than the mechanism that we've already mentioned. If your patient has a urinary catheter or is peeing on their own, you can monitor urine pH as well. And then ventilatory status. So if you have to give the bicarbonate, but they're having a decreased drive, they may have to become a ventilator patient. So when to use it, there's pretty few indications. So having a base excess of more than -10, so -11, -12, so on and so forth. Having a bicarbonate of less than 10 and a pH of less than 7.2 with associated clinical signs. That's it. So there's alternative drugs, which are not, unfortunately, really out there anymore, but something really interesting that I didn't know about. So trimethamine or THAM, it's an organic amine buffer that directly binds hydrogen ions to reduce the concentration of them. And then it also reduces the concentration of carbon dioxide produced compared to normal sodium bicarbonate. The unionized portion is freely diffusible into the cell, so it's thought to potentially be a more effective intracellular buffer, theoretically. It is an osmotic diuretic, so it can lead to polyuria, but it's no longer made. And then carbicarb, so it's an equal molar mixture of sodium carbonate and sodium bicarbonate. So it generates less carbon dioxide than the normal sodium bicarbonate. It does not increase lactate, and it does not lower intracellular pH. So if you ask me, this seems a lot safer, but it's not really made anymore, ? And these are just some of the many references. Just some pictures from the last several weeks of residency that I wanted to mention up here. This is my first ventilator patient that was on that time, 6 CRIs, so kind of like a tree of life. And down here is what my typical day looks like when I have to study. And this is just books, not just research articles.